Hello, everybody, and welcome back to IONM 1130. This is Unit 6, and today we're going to be talking about the brainstem audio evoked responses, shorthand known as BAERs. And this is probably the most complicated modality that we run, and its usage is pretty wide. We can get a lot of information out of the waveforms that we create using this modality. So at least with the professional examinations that you'll be taking, BAERs are usually pretty heavily tested, and that is because of all the different interpretations and clinical significance that can be drawn from these tests. So let's get into it. We're going to talk about what is a brainstem audio evoked response, how are they generated, the recording montages that we use, as well as the recording and stimulus parameters, and the alarm criteria. So the brainstem audio evoked responses, also known as ABRs for auditory brainstem responses, AEPs, auditory evoked potentials, and BAEPs, brainstem auditory evoked potentials. These are all the same exact test. You should file them away in the same folder. They are all the same. I usually refer to them as ABRs or BAERs most commonly, but any one of these can be used interchangeably. So the brainstem audio evoked response is comprised of 5 main waves. Waves 1, 2, 3, 4, and 5. And these are our markers. Here we're looking at 2 waveforms. This top one is going to be the ipsilateral ear, the ear that we're going to be testing. And then this other one is the contralateral ear. It is the other ear. And we'll go into what the difference is between the two of them. But from just looking at it, you can see ipsilateral has got 5 waves and contralateral has got 4 waves. And this is for a specific reason that we will get into. This is what the hardware actually looks like. This is the most common set that we use for the intraoperative usage of BAERs. We have the end right over here that plugs into the computer, and then these 2 transducer boxes, one for the left, one for the right, color-coded for left and right to keep them straight. And then we've got these plastic tubing, this little plastic insert at the end, which is probably the most critical piece. It is the cheapest piece and the one that you'll probably lose first. So just be aware when you're running these tests to keep an eye out for these little tiny plastic inserts, because if you lose them, you can't run the test. And it seems kind of silly that something so significant should be reliant on something so small. This is just a little plastic insert that connects the tubing to the earplug, and without it, the test doesn't work half as well, or at all, really, I should say. And here we have the earplugs, which are disposable. These will go inside the ear canal for the intraoperative usage. But this test doesn't have to be done only in the operating room. We can also use it in a clinical setting with over-the-ear headphones or over-the-ear earplugs. Basically any way to deliver the sound stimulus will suffice for this test. There's a difference between using the ear inserts and using the headphones, a difference in the latency that we should expect, and we'll talk about that later on. But as long as you can deliver a sound stimulus, an audio stimulus, then you should be able to run the BAERs as long as you're recording from the right spots. So let's talk about the stimulus parameters. First and foremost, you must stimulate unilaterally, meaning you're only testing one ear at a time. So we're going to choose, in this example, we're going to choose the right ear. I have the right side selected. And what happens is on the right ear, we're going to have this broadband clicking. It's going to be a series of clicks. And when you first open up these tests, you should always test out your kit, your ABR kit, to make sure it's working. And you'll hear very clearly what these clicks sound like. But in the other ear, we have what is called masking. It is white noise. It sounds like a hiss or what your television sounds like when it's not tuned into a channel. The purpose of the contralateral masking is to block out the click stimulus from the other ear. A lot of the auditory pathways cross over inside the brainstem, so the auditory cortex on one side receives information from both ears. And then there's also a phenomenon known as bone conduction of sound. So if you have your sound, your click stimulus up too high in the one ear that's receiving it, that sound could be transmitted across the bone of the head and enter into the contralateral ear, and that will contaminate the signal. So what you really want is you want the one ear that you're testing. In this case, we're going to say it's the right ear, but it could very easily be the left ear. Whichever ear it is, that one ear needs to be listening to clicking only, and the other ear needs to be listening to the white noise, the contralateral masking only. And the way that we do this is we stimulate that, we send the sound in at both times, but we're going to have the clicking at a higher decibel level than the masking. And in general, you want to have the clicking about 30 decibels higher than the masking. So I have it here set as 110 decibels for the clicking and 75 decibels for the masking. That's a 35 decibel difference, but 70 and 100 will work, 80 and 110 will work. Every patient is a little different. Sometimes the stimulating kits are a little bit different. So this, just like with your stimulation for SSEPs and for MEPs and for triggered EMGs, you want to do it on a case-by-case basis, and you fine-tune it during the procedure to make sure you are getting the kinds of signals that you need. And this is very high frequency stimulus, between 20 and 30 hertz, 20 and 30 clicks per second, very fast. And the click duration is 100 microseconds. This is standard. Your frequency can be adjusted if you have any noise that's coming in, or if the patient has some sort of hearing deficiency. Maybe you want to lower the frequency of your stimuli so that they're hearing it a little bit better. But in general, between 20 and 30 hertz will suffice. You see I have it set here to 27, and we have 100 microsecond pulse duration. Now the other type of stimulation parameter is the polarity of the click stimulus. And so we can choose here between rarefaction and condensation, or alternating, which is rarefaction followed by condensation followed by rarefaction. And basically the difference between rarefaction and condensation is the pressure of the sound wave. So if we start up here at the top, we got to think of sound waves as transverse waves. So in this example, we have the slinky, and the hand is holding the slinky, and it's pushing it in and out. And so this wave, this compressed portion, we can consider the wave, and the other part is the inactive part of the wave. This will move through the slinky, through the wave, in a lateral vector. And sound waves behave in this manner. So this part of the wave, this tight wave, is called condensation, and it is reflected by higher pressure. So this is condensation, whereas the other, the low pressure area of the wave is known as rarefaction. And if we come down here and we look at what the alternating signal will look like, we've got rarefaction followed by condensation, rarefaction, condensation, and it is a variation on the pressure of the sound wave, specifically the pressure that is being put on the tympanic membrane, the eardrum. So with condensation, the sound waves are pushing on the eardrum, pushing into the eardrum, and with rarefaction, it is pulling on the eardrum. So if you think of the tympanic membrane as a trampoline or some other flexible surface that moves in and out, left to right, convex to concave, that is the way that the eardrum is vibrating and behaving with these sound waves. And both condensation and rarefaction will cause a hearing, will cause the auditory nerve to send signals to the brain, but the actual delivery method is different. And so in general, we choose alternating. We try to get a mixture, an equal mixture of condensation and rarefaction with our stimulus. And this produces an even type of response from waves 1 through 5. If we were to stick with only condensation, only positive pressure, only sound that is pushing on the eardrum, that's going to make wave 1 larger. And if we do rarefaction, pulling on the eardrum, negative pressure on the eardrum, that's gonna amplify wave 5. So if you needed to look closer at wave 1 or wave 5, and we're going to go into exactly what wave 1 and wave 5 signifies as far as the anatomy and the pathway of the sound impulse, then you do it if you have to. But most of the time, 99% of the time, I would say you're going to be using alternating polarity. So you've got alternating broadband clicking stimuli with a pulse duration of 100 microseconds. That means each click lasts for 100 microseconds. And one click is going to be either condensation or rarefaction, and the next click is going to be the opposite one. So we're going to have 100 microseconds of, this would be low pressure, so rarefaction, 100 microseconds of condensation, 100 microseconds of rarefaction, 100 microseconds of condensation, and so on, and all throughout the procedure. And this is the method of stimulation. This is how the sound waves are put upon the ear, the tympanic membrane, and all the way through the inner ear to the auditory nerve. When we record, we have these are very small signals compared to your MEPs and your SSEPs. They're very, very small responses. And so our amplifier input has to reflect that. We lower this down to 160, maybe as much as 200, as low as 100 microvolts, but right in the middle, I think 160 is the right number for this. So any amplitude larger than 160 volts is not going to be a sound wave. It's not going to be a cortical response from the sound wave. It's going to be noise, and you don't want that coming into your amplifier. We want to have a lot of averages, where with SSEPs, we have between around 200 averages, 300 averages. We're going to have 10 times as many as that with our auditory responses. 1,500 to 3,000 averages is good. If you have very clean signals and you don't have any noise in the system, then you can certainly lower the averages, but start with it up high and you see what you get. You average out the noise, you average in the signal, and by the end of 3,000 averages, you can be pretty sure that you are picking up everything that is there to be picked up. The low frequency filter we're going to set at 30, high frequency filter at 3,000, and we're going to set our band pass pretty narrow between 40 and 1,000 hertz. So again, the difference between your high frequency filters, your low frequency filters, and your smoothing filters, in this case the band pass, is, we'll look up here, this is the range of signal frequency entering the amplifier. This is what is being acquired. This is what is coming in, and then this is what you are visualizing. So even though you've got up to 3,000 hertz of signals coming in, you're only going to be looking at 1,000. You can increase this number if you need to, but I like to have a nice smooth looking waveform. If you have to increase this, you absolutely can. You can open the smoothing filter to the limit of your actual filter, your high frequency filter, and that is going to be at your discretion based on how the signal appears. If it is noisy and there's a lot of squiggly lines inside of the waveforms, maybe you want to lower your bandpass so that you just look at the bigger picture. Your sweep length, you're going to be recording for 10 milliseconds. And your time base is going to be 1 millisecond per division. This is going to center your brainstem audio evoked responses right in the middle and give you a nice looking screen. Okay, our recording montages. Here it's going to get a little complicated, especially in relation to our SSEPs, but the thinking is exactly the same. But again, this is why the BAERs are going to be tested more rigorously than the ABRs because of how complicated it is. So the BAERs are recorded from one ear at a time, as we said. The ear that is being tested is referred to as the ipsilateral ear and is stimulated using a click stimulus. The contralateral ear is stimulated using white noise for masking. And so the three typical montages that we have for each ear, we're going to have A1 to CPZ, so this would be the left ear, A2 to CPZ, this is the right ear, and then our cervical channel to CPZ. This is going to pick up both left and right. And in fact, both of these are going to pick up left and right to different degrees. But think of your A1 as your left ear and your A2 as your right ear. Wave 1 should be present in the ipsilateral ear only. So if we look back here at this, we're stimulating, let's call this the right ear. So this would be the A2 to CPZ channel, and this will be A1 to CPZ. And so what's happening is in the right ear, wave 1 is our click. Wave 1 is the actual signal from the ear. We're gonna talk about exactly where this comes from, but let's call this the click. So we want to see this in the ipsilateral ear. That's what we're stimulating. This is what we're recording. Over here in the contralateral ear, we need to have the masking. Looks like we have a little bit of a bump here, but nowhere near what we're seeing here. So the masking is working. Waves 2 through 5 are recorded not from the ear, but recorded from the brain stem, and can be picked up in all channels. So if you see wave 1 over here in the contralateral ear, then that means that your stimulation intensity is too high and your sound is being conducted through the bone, and the contralateral ear is hearing the clicking, or perhaps your masking, your white noise is not high enough to block out the sound, and even though you're not getting some bone conduction, you might be actually hearing the clicking through the headphone, if that's the case. Either way, you want to fine tune your stimulation so that you are not seeing wave 1 in your contralateral ear. You only want wave 1 in the ipsilateral ear. And let's talk about waves 2 through 5 for a second. We have to think all the way back to our SSEP lecture about our subcortical signals and the cephalic to non-cephalic recording method. So just to go back over that, let me get my cursor up here. And we've got our pen. So what happens when the signal comes into the brainstem? Remember, it radiates out in equipotential lines. These lines all have the same intensity of stimulation, and basically that signal makes its way to the scalp, to where our electrodes are sitting at the same exact intensity. So what happens is when you have both your channels recording the same signal, they cancel out. The common mode rejection takes over, and you don't get a signal. So when we are recording waves 2 through 5, it has to be done with the cephalic to non-cephalic recording. And this is what that represents. A1 and A2 are considered non-cephalic, and CPZ is the cephalic recording. So our montages are going to be C1 or C2, reference to CPZ, and then the other one, we're going to have our CV, our cervical potential, which is also a non-cephalic electrode, reference to CPZ. So every single one of our channels is going to be a non-cephalic electrode, non-cephalic being the active electrode, and then our cephalic electrode is our reference. Non-cephalic is negative, cephalic is positive. And what this is going to do is this is going to create our waveforms that are all vertex positive, meaning every one of these waveforms is going in the same direction. So this is called a mixed field response. So with SSEPs, we had near field responses, we have far field responses, and for SSEPs, those are pretty much considered separate. With brainstem auditory evoked responses, we have both near field and far field responses together. And so this is called a mixed field response. And we have to make sense of this. And this might seem a little confusing and complicated, but if you remember all the way back to that little square with the positives and minuses and the arrows going up and down, indicating our waveform deflections, this is going to make a lot more sense. So the first thing we have to do is we have to understand the generators of waves 1 through 5. Where are these signals coming from? So wave 1 is the distal cochlear nerve. Wave 2, the proximal cochlear nerve. Wave 3, the superior olivary complex. Wave 4, the lateral lemniscus. And wave 5, the inferior colliculus. We're going to look at these pictures in more detail, but we have 1, 2, 3, 4, 5, and you can if you look in there, you see exactly where the signal is being generated within the anatomy. And this is something you're going to have to memorize. There's no easy way to commit this to memory. You have to just commit this one to memory. There is a very useful acronym, which we're going to talk about in a second. But first, let's continue with this. The montage here, A1 to CZ. Okay, in this case, we're gonna call this the left ear. We're stimulating the left ear, and we get waves 1 through 5. The clicking is happening in the left ear. We see our click, and we have the proximal nerve, the superior olivary complex, the lateral lemniscus, and the inferior colliculus signals coming in. And over here in the contralateral ear, we see no clicking, but the other responses coming from the brainstem are present. So wave 1, like I said, from the ear, the sound travels into the ear, goes through the cochlear, stimulates the hair cells inside the cochlear, and then the sound comes out of the auditory nerve. And as it exits the auditory nerve, that's where we get wave 1. Wave 2, as the nerve enters the brainstem, as it travels down the path of the axon and enters the brainstem, that's where wave 2 occurs. Wave 3, the superior olivary complex. This is the nucleus inside of the pons. This is where that nerve crosses over and hits a nucleus. There's a synapse there. It's a very strong potential. Wave 3 is usually fairly clear. So by now, the signal is inside the pons. Wave 4, the lateral lemniscus. This is as the signal is traveling up the pons, up the brainstem towards wave 5, the inferior colliculus. And again, we're going to go into more details of this. These are those pictures again, and we're going to see them a little more. Waves 1 through 5. It's important to know where these waves are generated, where along the sound, the auditory pathway these waves come from, because it's going to help you come to conclusions about what you're seeing when some of these waves change. Now, the helpful acronym that I usually use is acosolic. Acosolic. And A for auditory nerve, co for the distal cochlear nerve, so for the superior olivary complex, L for the lateral lemniscus. It should really be 2 L's, but it's confusing to write that out and see it with 2 L's. I think 1 L looks better, but you need to know it's the lateral lemniscus, which is 2 L's. And then finally the IC, the inferior colliculus. So when you're committing this to memory, remember acosolic. Acosolic. And that's going to be a helpful acronym to remembering what the names are for waves 1, for the anatomy, the sources of the generation of waves 1 through 5. Let's go a little closer. Wave 1, the distal auditory nerve. So the auditory nerve is the 8th cranial nerve, the auditory nerve, also known as the vestibulocochlear nerve. And this is the first wave. This is the clicking. So we have the sound entering in. We have our ear plug right here in the ear canal, or perhaps a headphone over the ear. The sound is generated. It hits the eardrum. It goes through the hammer mechanical mechanisms here of the malleus, the incus, and the stapes, stimulates the fluid inside of the cochlear, causes it to vibrate and activate the hair cells inside the cochlear, which then converts this mechanical signal into a chemical signal, which then becomes an electric signal traveling down the auditory nerve. So as the nerve becomes activated by the sound, that is where we get wave 1. And this correlates to the clicking sound. Wave 2, the proximal auditory nerve, so that nerve that's leaving the cochlear and traveling up into the pons. It's right in this area, right above the medulla, the inferior portion of the pons. As the nerve enters the pons, this is where wave 2 is generated. And it goes into the cochlear nucleus of the pons. And wave 3, the superior olivary complex, is inside of the pons. Let's look over here on this signal. So we have the nerve coming in here to the cochlear nucleus, where wave 2 is generated, and then the sound crosses over to the superior olivary complex right here. So we've got a nerve coming in, a synapse right here, another nerve going over here to another synapse over here. And every time we have the synapse, we see a wave. We see a very clear wave for waves 2 and 3. And then wave 4, the lateral lemniscus, as that signal is traveling up the pons into the midbrain, this is wave 4. The lateral lemniscus is it is a tract of axons. It is many different axons all traveling together, and this traveling signal generates wave 4. It's called the lateral lemniscus. And then lastly, wave 5, the inferior colliculus at the rostral pons, the superior pons, the highest, the tallest part of the pons, closest to the top of the head, the inferior colliculus. This is no longer the pons, it is actually the midbrain, and the inferior colliculus is the principal auditory nucleus of the midbrain. From here, the signals travel all the way up into the temporal lobe, where the sound is processed by the brain. But wave 5 is really the last obligate peak that we have. Even though there are waves and signals that can be seen beyond wave 5, if you were to extend your recording time, wave 5 is kind of where we stop looking for BAERs. So, getting back to the mixed field topic, we need to think about where these signals are being generated from and which electrode are they being recorded by. So remember, our montage is going to be A1 or A2 as our negative, reference to CPZ, our positive. And so let's go through these one by one. Okay? Wave 1, the clicking recorded from A1. The electrode is somewhere over here on A1, and the stimulus is being generated right over here. This is a near field response. So we have a negative near field signal coming into the negative channel, and that creates an upward deflection. Now, wave 2. Wave 2 is in the middle, is in the brainstem. So that signal radiates out. It's going to be a far field signal, and we're gonna pick up that far field signal with our CPZ electrode. So we're going to have a positive far field signal coming into our positive reference electrode, and that's going to create an upward deflection. And actually, the same exact thing happens for waves 3, 4, and 5. These are all deep structures which send out electrical signals which are far field signals. These are positive waveform polarity signals which are recorded by the reference electrode in our montage. So we have our positive signal into our positive channel, and we get an upward deflection. So this is why waves 1 through 5 are all seen moving upward, because wave 1 is up here in this box. We've got the near field signal into the active electrode, and then the other 4 are the far field positive signal into the reference electrode. So we get vertex positive waveforms, even though they are being recorded in different manners. So the first thing, once we have everything set up and we're starting to acquire our data, we need to identify waves 1 and 5. Now, wave 1 is present usually 1 to 2 milliseconds after the stimulus. So if we're looking at our grid here, we can see the stimulus all the way, assume the stimulus is all the way over here on the right, and 1 to 2 milliseconds, we see wave 1. And over here, we see wave 1. This would be the right ear, this would be the left ear. This is the contralateral ear for the left. We don't really see wave 1 here. We kind of see a little wave 1 in this trace, but not so much in the baseline or the other one, or the building. So I'm happy with this. But basically, first thing you want to identify is wave 1. The next wave is wave 5. Wave 5 is probably the most obvious wave that you're going to see. It's going to appear 5 to 7 milliseconds following the stimulus, and it's characterized by this large peak and this large drop-off next to it. This is characteristic of wave 5. You got your big high peak followed by your large depolarization following that wave 5 peak. So you identify wave 1, you identify wave 5, and then you can assume wave 3 is in the middle. Excuse me. All right. Wave 5 is present in both ears. Wave 1 is present in the ipsilateral ear only. And let me explain to you this montage that we're looking at real fast. So we've got over here our left-sided stimulation, and over here our right-sided stimulation. And both these stimulations are broken down. I have my ipsilateral recordings and my contralateral recordings for both ears. So this would be our ipsilateral recording from our A1 electrode, our ipsilateral recording from our cervical channel, and then our contralateral recording from the other ear. And we have that split in both ways. Sometimes you'll see all 3 of these along the same grid. I like to separate them out. I think it's easier for me to remember which one is the contralateral side when I have them divided horizontally. But it doesn't have to look like this. I just prefer it to look like this. What's important is that you have your montages properly labeled and you understand what these montages stand for. Obviously, A1, because it's a odd number, it's going to be a left-sided electrode. A2 which is an even number. That's going to be our right-sided electrode, and that convention holds for all of our 1020 markers, which we should all be very familiar with by now. So now that we have identified waves 1, 3, and 5, these are our obligate peaks, 1, 3, and 5. Waves 2 and 4, not as important as waves 1, 3, and 5. The next parameter, besides the absolute latency, so where exactly is wave 1 occurring, where exactly is wave 5 occurring, and wave 3, we have interpeak latencies. And interpeak latencies are really the primary parameter that we're looking at. Absolute latency is less important. It doesn't really matter what the latency is of your baseline. It matters when your signals deviate from that baseline. So you stimulate, you get the numbers that you get the latencies that are there, and the time that it takes for the sound to go from peak 1 to peak 3 matters. The time that it takes to go from peak 3 to peak 5 matters. And then the time that it takes to go from peak 1 to peak 5 matters. And remember, wave 1 is our auditory nerve. Wave 3, the superior olivary complex. That's going to be about 2 milliseconds. Between waves 3 and 5, also about 2 milliseconds. And then from 1 to 5, we're going to see about 4 milliseconds. So the time that it takes to go from here to here is about 4 milliseconds. So if we see wave 1 coming in at 2 milliseconds, we're going to expect to see wave 5 coming in at 6 milliseconds. And when we're thinking about what our alarm criteria is, any changes in latency, any increases specifically in latency of 1 millisecond need to be reported to the surgeon. And decreases in amplitude of 50% should be reported to the surgeon as well. So we can see here in these two pictures, these are both the right ear. This is baseline. I have my markers in place. So this marker right here is sitting on top of wave 5. And then this marker out here I have set for as like a warning. And when I see that we have our baseline marker here, when I see our signals traveling out towards this, I have this set to 0.8 milliseconds. This is when I sound the alarm. This is when I alert the surgeon. So having these markers in place are definitely helpful for you, so you don't have to constantly calculate and count these little divisions. It's nice to have the computer do some of the work for you. So you want to monitor the changes from baseline. And those changes, 1 millisecond increase in latency, and then a 50% decrease of amplitude. These are what the surgeon needs to be told about. So one important note is that when we're using these earphones, these ear inserts, this tube, this plastic tubing adds time. It adds about 1 millisecond or 0.9 milliseconds. So the sound is being generated in these boxes, and then the sound has to travel all the way down into the earpiece, into the ear, and through the ear to the nerve. And that whole thing can take about 2 to 2.5 milliseconds. That's pretty common. It's important to note that when you have over-the-ear headphones, when the sound is being delivered to the ear directly and you don't have this distance, you don't have that change in latency. So you'll see your wave 1 with your earphones appearing about 1 millisecond earlier than if you had these tubes in place. And that's just a function of distance. The sound has to travel that extra distance, and that takes time. And so that time shows up on the grid, and that's normal. Something is a factor that you need to be aware of and have in the back of your mind. So these add about 0.9 or 1 millisecond latency extension. So when we use ABRs or BAERs in the operating room, it can be used in a variety of settings. Any surgeries involving the auditory nerve, the pons, the midbrain, the brainstem, the temporal lobe, or even vascular procedures involving the posterior cranial artery, which feeds the brainstem. We can use BAERs for information, because all of these anatomical locations produce one or more of these waves. So if we have a normal baseline and then something were to happen to any one of these locations along the way, any one of these waveforms could be affected. So we need to remember where these waveforms are being generated and what is actually going on in the surgery and how that surgical procedure could affect that specific wave. And we'll talk about some specifics for this. Some of these procedures, microvascular decompression of the trigeminal nerve for trigeminal neuralgia. We do brainstem auditory tests for that. The trigeminal nerve is the 5th cranial nerve, and the pathway goes right by the 8th, the auditory nerve. And so sometimes the surgeon has to retract the 8th nerve out of the way to get to the 5th nerve, the 5th cranial nerve. And so when he's retracting, we want to make sure that the nerve is okay. It's still continuing to transmit. And that's actually what these one of those procedures are, where these screenshots are coming from. A microvascular decompression procedure, shorthand known as an MVD, microvascular decompression. Also an acoustic neuroma, which would be a tumor on the actual auditory nerve. We would use ABRs, BAERs for that. A tumor on the temporal lobe or brainstem, we would want to monitor the auditory pathway for that. And then retraction of the cerebellum. Anytime the cerebellum has to be retracted, that's going to pull a little bit on the brainstem, put pressure on the inferior colliculus. We want to make sure that no damage is done to these signals. So using our ABRs, our BAERs, for these specific types of surgical procedures or steps inside of a surgical procedure is useful information. Conductive hearing loss is a condition where the sound waves have trouble being translated into an auditory signal in the nervous system. So the problem here exists between the tympanic membrane, the eardrum, and the nerve, the distal cochlear nerve. In other words, it is the mechanical steps involved in hearing. So that pathway, the sound goes into the ear, goes through the inner ear, the bones inside there, into the fluid and the cochlear, and that is what generates the sound impulse. So when we have a problem with that area, that is called conductive hearing loss, as opposed to neurogenic hearing loss, where the issue is somewhere along the nerve or the brainstem farther down the line. Conductive hearing loss will affect wave 1 specifically, because wave 1 is what's hearing that click. But once that signal has made it onto the nerve, if there's no other issues down the line, then all the other signals, the inner peak latencies wave, wave 3, wave 5, they're all going to be fine. It's the conductive hearing loss is a problem delivering the sound to the nerve, and it only affects wave 1. Some other changes that we need to worry about: ischemia, lack of blood supply to the nerve or to the ear or to any of the structures, will cause a change. When we see the cochlear ischemia, we're going to see a loss of all of our waveforms. The cochlear is not being given the blood, the oxygenated blood that it needs, so it's not going to generate a sound, and that sound is not going to be transmitted through the system, through the pathway. So we're going to get nothing when we have cochlear ischemia. When we see injury to the distal auditory nerve, so the point where the nerve is coming out of the cochlear, any type of injury in that area will cause a wave 1 decrease in amplitude, and then an increase in latencies of waves 3 and 5. So wave 1 is gonna come in, and then it might have trouble going down the line. But once we're going to see changes in the latencies of waves 3 and 5, and we're going to see no changes in the inner peak latencies between 1 through 5. Next, the injury to the proximal auditory nerve. So that the same nerve, but as it goes into the brainstem, we're going to see a normal wave 1. Again, the increase in latencies on waves 3 and 5. And so here we might actually get a change in the inner peak latencies depending on the severity. We got our distal nerve coming right here, and then something happens along this pathway. It's going to cause this wave to elongate and show up later. So when our inner peak latencies between 1 and 3 change, that we can be sure that something is happening at the brainstem area as the nerve enters the brainstem. If we have an injury to the brainstem, we're going to see, again, a normal wave 1. I should be over here. Normal wave 1. And then increase in the latencies of waves 5 and possibly wave 3, depending on the location of that brainstem injury, and possibly a decrease in the amplitude of wave 5. And then if we have a lesion in the rostral pons, so the part of the brain where wave 5 is being generated, that's the only one that's going to be affected. Everything before that is normal. So waves 1, waves 3, the inner peak latencies between 1 and 3, those are all normal. And wave 5 is going to be affected. Some other things to think about: if the interrupted signal, if we have an interruption to the signal in the inner ear, which could be caused by fluid in the ear or kinking of that plastic tubing, or potentially damage to the cochlear, we're going to see that wave 1 delay. Remember, this is a conduction issue here. Trouble with the sound getting to the eardrum, getting through the eardrum, and getting out to the nerve. That's going to be our wave 1 delays. An interruption of the auditory nerve conduction, so from the cochlear all the way to the brainstem, the actual nerve, we're going to see the inner peak latencies of 1 to 3 increase. And this can be done if the nerve is damaged or if there is ischemia to the nerve, if the blood supply to the nerve. So if the nerve is stretched or damaged by mechanical means during a surgery, we'll see that. Disruption of the signal path through the pons in the actual brainstem. If there's a lesion or something happens in the brainstem, ischemia to the pons or mechanical damage to the pons, our 3 to 5 inner peak latencies are going to be affected. Wave 1 is unaffected because that's not where the problem is. The problem is after wave 1 inside the brainstem. So when we see the inner peak latency increases in these specific areas, we then know to think about what could be happening at those different areas. Is it at the ear? Is it along the nerve? Is it as the nerve goes into the brainstem? Is it inside the brainstem? Depending on the changes in our signals, we can make these inferences alongside with our neurologist and in communication with our surgeon, of course. So in conclusion, the brainstem audio evoked responses, it is a complicated test comprised of mixed field signals and 5 peaks, 5 waves. We have one ear which is stimulated at a time. The ipsilateral ear receives the broadband clicks, and the contralateral ear receives the white noise. If you want to check the other ear, you've got to switch these. You've got to stimulate. If we're looking at the left ear gets the clicks and the right ear gets the masking. When we check the other ear, we switch that. The right ear gets the clicks and the left ear gets the masking. And we do those one at a time. You can't have both ears getting the clicks because then you can't be sure that you are testing the individual auditory pathways. Because these auditory pathways, they cross over and they radiate out, you cannot have contamination from one ear bleeding into sound contamination bleeding into the other ear and potentially causing false positive readings. Wave 1 needs to be present in the ipsilateral ear only. That is going to indicate that your clicking is good and your masking in the other ear is good. Changes from baseline latency of 1 milliseconds or more need to be alerted to the surgeon. Changes from baseline amplitude of 50% decrease should be alerted to the surgeon. And the interpeak latencies, the change in time between waves 1 and 3, between waves 3 and 5, and between 1 and 5 can reflect a variety of surgical complications. And this variety, this complicated nature of these tests, this is why ABRs are used so heavily in the clinical testing setting and with the professional testing. There's a lot of information that can be drawn from ABRs, and the test makers will use this complicated nature of the test to see how well you can think around problems. Do you know the anatomy? Do you know what is going on in the surgery? Do you know what this specific change could mean for what happened in the surgery? So learn your ABRs, especially before you take these professional examinations. Spend a lot of time studying the specifics of the brainstem audio evoked potentials. So that's it for ABRs. Next week is our final week. We're gonna have a final review. I need to find a time which is acceptable for everybody. If you wish to join, I'm gonna send out a GoToMeeting link, and we're gonna have a little webinar review session. If you have any questions, then is the time to ask them. Certainly before the exam opens up. It's going to be online, just like our quizzes have been since week 2. And the final exam will be due on Tuesday, August 23rd at 8 in the morning. So you'll have the whole weekend and hopefully the whole week to take this exam. And also our writing assignment is due on the same day at the same time. So that is the absolute deadline. You can certainly submit these. You can take the test and submit the test before this deadline. You can submit your paper before this deadline, and I encourage you to do so. But that is That is the absolute line in the sand. There will be no late submissions accepted for the final exam and for the writing assignment, as I have done with the quizzes previously. So just please be aware of this deadline as we approach the final week 7. And I wish you all the best of luck with the quiz. I hope everyone has a wonderful week, and I look forward to speaking with you all during our review session. All right. Have a great week, and I will speak with you soon.